Hello everyone and welcome to today's QI Talk Time. Today's QI Talk Time is about embedding patient and family engagement in a Model 3 hospital. And I'm delighted to have our colleagues from Mayo with us today to tell us all about their journey, and thanks a million for facilitating that today for us. Our speakers today, we have a number of different people from Mayo who are joining us online. So if you want to wave hello to the audience as they introduce you. Firstly, we have Catherine Donoghue. She's the General Manager in Mayo Hospital and has led the management team to deliver on the implementation of the framework for improving quality. So the main focus was to have a culture of QI through all levels of the hospital, and this requires embedding patient and family engagement as the key element to the success of this work. Catherine's previous experience as Director of Nursing and Midwifery has driven this project. Then we have, delighted that we have Rachel Bracken with us today as well. She's the Patient and Family Experience Advisor and has been working in Mayo Hospital on the implementation of the Mayo approach since 2017. She's had a number of healthcare interventions and brings great experience to the work. Rachel has been working in quality assurance in the pharmaceutical and medical device industries over the past 20 years. And next we have Fiona McGrath. So Fiona's a physiotherapist by background and is one of the leads on the patient and family engagement in Mayo Hospital. Fiona has been the physio manager in the hospital since 2001 and is currently working as project manager on integrated care for older persons in Mayo. Seamus then, Seamus is in the background there. He is the principal social worker in Mayo University Hospital since 2001 and has worked extensively with patients and families throughout his career. Seamus is one of the leads on the patient and family engagement in the hospital. So next, moving on then, just a quick bit on housekeeping. So today we want to address all of our listeners' questions, queries, comments as we go along. So please use the chat box, the little blue bubble, to ask any questions off the panel as we go through. We'll deal with those at the end. The telephone number is there again for anyone who needs it. We are very active on Twitter, so please do follow us at QI Talk Time, and also just tweet any photos, or if there's a group of you in the room, there is currently 60 online, which is fantastic. So great to have you from all over the country. So if you want to type in and let us know where you are, that'd be great. Without further ado, I'm going to hand over to, I think, maybe Catherine starting first, and we look forward to hearing all about your experience in Mayo. Thank you.
Okay, first of all, thanks, Roisin, for giving us the opportunity to share our experience with others throughout the country. Just kind of a very brief introduction as to what we are. So it's a Model 3 hospital. We've got just over 300 beds, and we're part of the Sale to Hospital group. Kind of looked at this to try and embed it in so that, you know, starting from the beginning as to what motivated us to try and drive forward with patient and family engagement. Back, I suppose, and I can only talk from my experience in the hospital, in 2011, we kind of started on a kind of a structured journey towards quality improvement. And that kind of coincided with the launch of the National Standards for Safer, Better Healthcare. And we started looking at trying to have, you know, culture of quality improvement and safety. And there was a lot of work kind of done internally in the hospital during that period of time. The patient safety culture survey came out in and around that time as well. And it was obvious that as a management team, we had one perception of where we were, but the staff that were actually working out in the front line had a different perception. So again, it refocused our minds as to what we needed to do to have a culture of quality improvement. In 2014, we had we ran a conference here on quality and patient safety, and we had international speakers. It was a hugely successful day, and there was great enthusiasm from the staff's point of view. So we knew that we had a group of staff within the hospital who would participate on a journey towards quality improvement. And we signed a declaration at that particular symposium with Philip Crowley present at it to say that we would have a commitment of a constant focus towards quality improvement. I suppose then in 2016, there was an opportunity for driving it forward in a more structured way. And again, I'll kind of go through the ins and outs of 2016 and what opportunity lay on that. But it was a good chance for us to implement the framework, or I suppose utilize the framework for quality improvement at driving forward our ambition for excellence. So in 2018, we've really kind of started now, 2018, 2019, to start to see the work that has happened through the hospital and the impact that it's actually bringing forward. So I suppose the commitment for quality and patient safety, like I said at the very beginning, was very much about trying to embed the standards for safer, better healthcare, which is a requirement of us as an acute hospital. And an awful lot of that centred around every time we talked about it and looked at it, it was about the service user, about meaningful patient engagement. And at that point, it was trying to say, how could we really embed that responsibility for quality improvement in meeting these standards with all staff members in the hospital? So we looked again at that, incorporating it into our, terms of reference and how we ran meetings. And again, it was, there was pockets of improvement and pockets of focus on that side of it. So then we thought, okay, we're going to have to really kind of ensure that the structures that we put in place will, I suppose, support change in the future from an organizational point of view. And I think anybody who's involved in management will actually see that we're constantly challenged by changing structures from integrated care to CHOs and acute hospitals and hospital groups and whatever is coming for the future. So it was important that whatever we did, it actually met with what was going to happen now and what potentially could change in the future, so that whatever we did, we would have sustainability. So in 2016, like I said, the environment was just right at that time. We had pretty much an overall change in the management team in the hospital as it happened to people moving on, retirements. I took up the job as a general manager, which then gave me that bit more scope throughout the entire hospital for, I suppose, influencing change and supporting change as the general manager. And so again, I think it was in August 16, about a month after taking up position, we reached out to National QI and had a conversation with Dr. Crowley about how we could progress this on, and just really embedding quality improvement across all areas. It was very evident that the answer to doing that was good, solid patient engagement. And I had been at a conference, I think it was early in 2016, run by the INAM, the Irish Association of Directors of Nursing Midwifery, and they were talking about patient engagement, and I heard about the Canadian experience, and they felt it was very much like a game changer in relation to quality improvement and spreading the responsibility for quality improvement. And then coinciding with that was the launch of the framework for quality improvement. So all of a sudden we had a kind of a path forward to try and make the changes that we wanted, and the commitment to having it genuinely and meaningful patient engagement being the driver in it. So we also reached out to Canada at that point, and they were willing to work with us from the learning perspective that they had, and both Rachel and Fiona will go through more in the detail on that. One of the things then, we had to go back to the hospital management team, because it was really important that we all owned this plan for the future. So we actually agreed an aim statement to try and move this on in the hospital, and it literally was that we would achieve excellence through securing, again, meaningful patient engagement from the bedside to the management table, driven by engaged staff from all disciplines, grades, who are empowered by a commitment of support from senior management for continuous quality improvement. So this couldn't sit solely with just bringing patient engagement. Otherwise, we still had a responsibility for having safe care. We had a responsibility for that, we could develop our staff. We absolutely had to make sure that we had good, strong clinical governance and overall governance in the hospital. So the framework was ideal to actually set it forward and put it in a safe process of implementing patient and family engagement. And that's how we drove it forward. So the first thing we did was accepted as a management team that we were going to look at all of the areas of the framework, including obviously the patient and family engagement, which is what we're talking about today. And the first thing we did was we set the governance right so that we had a very safe way of leading forward on it. So we did our driver diagram. and we had our patient and family engagement plan, and both Fiona and Rachel will take it from there.
Okay, so moving across to myself then, so I was nominated as one of the leads in the hospital to work on this patient and family engagement journey, and I worked with my colleague Seamus Moran, social worker, and Dr. Mayo, consultant obstetrician here. And I suppose the three of us in early 2017 came together, and what we had to do was really to establish and empower a team within the hospital who was going to actually lead out on the patient and family engagement journey. The first thing we had to do, and from the outset we have always worked with the patient experience advisors, we knew some people who had used services within the hospital, so we hand selected 4 people to work with us, and they became our lead patient experience advisors who worked with us from the very outset. And Rachel will explain a little bit more as to how she came to be one of those lead patient experience advisors. Then we also needed hospital staff to work with us, so we wanted people who were really going to champion the patient and family engagement cause within the hospital so that it would become embedded. And again, we selected a group of staff champions, put out information looking for people to join us, and again, this was very multidisciplinary, so we had representation from nursing, medical, from support staff, from health and social care professionals. And this was our plan. We really had to look at how we were going to recruit, induct, orientate and educate the first cohort of patient experience advisors in Mayo University Hospital. So the first meeting happened of the bigger group, the implementation team as we became known, happened in April 2017. So as Catherine had said, the journey, she sort of filled you in on the journey up to 2017, where we actually had our first implementation committee meeting. Again, we were a very disparate group of people that actually came together. So we had to actually take quite a bit of time getting to know each other. We had to sort of understand each other, understand people's journeys, people's stories, where they had come from to actually get to that table. So throughout the summer of 2017, I'd say we actually spent quite a bit of time getting to know each other. We also had our terms of reference, which were very much aligned with the hospital management terms of reference, and we had to sort of work with that and gain agreement that everybody bought into what we were going to do. We had a lot of discussions about what patient-centred care meant, about what patient and family engagement actually meant. And you'll see the tree, which is actually on the bottom of the slide. We worked on that, and the group, the implementation committee, developed that as their logo. And the words that are on the trees are the types of words, and I suppose they're widely used now within healthcare, but they were the words that our group around the table decided really meant patients were engaged and that you were delivering person-centred care. Nothing about me without me became our logo, and that's on all of our information, and that's anything to do with a patient should be inclusive of the patient. That's the ethos that we work towards. We had a lot of discussion about what is a patient experience advisor, and we were actually able to link with our colleagues in Canada, and they gave us a lot of support around this. A lot of people think that an advisor advises patients when they're actually in the hospital. A lot of people sort of thought it was more of an advocacy role, but a lot of discussions really clarified for us what a patient experience advisor role was. And there was agreement amongst the group on that. And the role is, it's very much the person comes to the table and brings their experience of being the patient to the table. So that took us some time. When we had that done, we were able to develop an information leaflet, which was circulated widely within the hospital and outside. And then we did a number of awareness-raising sessions that included the staff and the public. We set ourselves up in the foyer of the hospital. We set ourselves up in the canteen. So really just trying, in that summer of 2017, to get people more aware of the patient and family engagement. So then in terms of recruiting patient experience advisors, we had to work with our HR department, and it was great because a representative of the HR department came and sat on our implementation committee. We went out and did a public media campaign. Catherine, as the general manager, was speaking on the radio about work within the hospital and promoted this whole area. We actually put an ad in the local papers that we were going to be recruiting patient experience advisors, and we actually ran an open evening in the hospital in October of 2017, where anybody was able to come and hear more about our work. We had to design an application form again. We worked with Canada and the HR department in terms of designing the application form. And then we had to design a screening process. So people who were interested in being an advisor and working with us, we didn't want to have to put them through an interview process, but we did have to put them through a screening process to learn a little bit more about them, to learn the areas that they had experience in, and just that they could meet us and sort of talk through any concerns that they had with us. One thing which was very important for us to take on board, and Canada were very strong with this, is that when you're working with an advisor, that the advisor is ready to engage with you as an advisor. And I suppose that means that anybody who maybe has an unresolved issue with the service or is going through a complaint or anything like that, that they wouldn't really be at the right stage. You would need to ensure that that process was completely finished in order for them to be able to come and to be ready to engage as a patient experience advisor. Once we had that whole process done, we then we had a subgroup who were working on induction, and the induction booklet was developed. So we looked at all the things that would be important for an advisor to know if they were coming to work with us. We had our induction evening, so we recruited at the end of 2017 into January 2018, and then we had our induction evening for 20 patient experience advisors in March 2018. A tour of the hospital was included as part of that induction, and this is very important so as people could understand how the hospital was laid out, what the ward structures was, what our processes were. And we had originally done this tour of the hospital for the lead advisors, and they had found this very, very helpful. So that's something that's part and parcel now of our induction process. We also put in place a buddy up system, and this was any advisor who was going to be working with any committee in the hospital, they were linked to one of the three leads, to either myself, Seamus or Maeve, in order to mentor them, support them, and make sure that they were felt supported in the work that they were actually doing. Education and education on patient and family engagement is a big focus, was the big focus for 2018. We had to look at what education needs our patient experience advisors had, and to make sure that we put that in place for them. We also had, it's a very new process, putting patient experience advisors sitting on hospital committees. So we had to meet with the committees, work with the committees, and give the chairpersons of those committees the mentoring and support they needed in order for them to have the advisors working with them. And now, into 2019, our big education focus is very much on the staff within the hospital and any students who are working within our institution. So just to give you a flavour of where our advisors sit at the moment, we have patient experience advisors on medication safety, on our older persons forum, on our nutrition steering committee, and the advisor has also been part of some of our nutrition audits in the hospital. We had a new paediatric decision unit developed in 2018, and there was a patient advisor sat on that committee. They're sitting on our end-of-life care committee, and now just recently staff engagement committee have come to us looking for an advisor to work with them in terms of the staff awards that will go on in the hospital. So that's been a new move this year. And then within CELTA are now sort of moving towards the patient engagement strategy. So our advisors are part of that work. And then another thing which we actually did in 2018, which we still have a little bit of work to do on, we recorded 3 patient stories, and we have excellent stories from 3 of our patients, and they're going to be used for education. They just need a little bit of auditing, which we haven't managed to do yet. So staff education is huge now. This is the big driver, and I suppose very much ties in with the whole quality improvement and actually bringing that patient engagement to the bedside. And it's really around embedding the cultural change at the hospital. So what have we done? We have our logo and we have our information leaflet. We have information on the hospital website, so anybody who logs in, any staff member, member of the public, the information is there about the work we're doing. We have worked end of last year, beginning of this year, to develop an education module, and we have an excellent facilitated education module, which it probably takes about an hour and 15 minutes, but there's a lot of work going into that. We have had 5 sessions with staff, and the feedback that has come back from the staff who've attended those sessions has been very positive, but it is actually quite difficult in terms of training to get staff released to attend away from the clinical environment. So we're now actually looking at, the group's now actually looking at how we bring that education to the clinical area, how we look at what educational forums are already in place within the hospital and how we can actually tap into those. So I'm now going to hand over to Rachel, who's been working with us since 2017.
Hi, I'm Rachel. So I'm a patient experience advisor, and I suppose just to give you a bit of background of me, I had a bad run of ill health over the period 2015 2016, and I suppose I had 5 A&E visits to Mayo University Hospital during an 18-month period in that time, and I had 2 surgeries as well during that time. So I also have an underlying condition, lifelong condition, Addison's disease, which is an inability of the body to produce cortisol in response to stress. So it requires timely delivery of steroids alongside whatever acute condition you might present to A&E with. So I suppose there was a couple of issues around, I felt, not being listened to at the time, and a couple of the visits to the hospital, although overall, obviously I'm still here and the hospital was a very positive experience. But I had written a number of letters of complaint over that period, kind of 2015, 2016, and I had always offered my services, that I would collaborate with the hospital because I suppose I have a degree in biochemistry and I have worked in the pharmaceutical industry, pharmaceutical and medical device industries in quality assurance positions for about 20 years. So one of the parts of my role in my work is to work on corrective and preventive actions and to get to the true root cause of something and not just kind of put a finger in the dam on something, but really to get in at systematic corrections. So I thought I had something to offer, and I suppose in each of my letters of complaint, and I think there were about 3 of them over that time period, I did offer to make a difference. So I suppose when I got the call from Fiona in February 2017 to ask would I be interested in coming on this committee, I had to, act on my offer and make good on that offer. So I delivered on that, and I do believe that this would make patients safer in the hospitals, and also staff work would be easier. If you just take that extra few little minutes of time and work with your patient and collaborate, then you'll get a much better outcome for everybody. Oh yeah, our video's gone, is it? Yeah. I might have hit off something there. Go back. Yeah, sorry. So I suppose my experience so far on the patient implementation committee was that it was a very positive and enthusiastic start. We were very, all the staff champions, the national people that were on the committee at the start, and the 4 of us patient advisors, we were all very keen and enthusiastic. For those of us that were not working within the hospital or within Safety Group or HSE, we learned a lot about the workings of the hospital, the health system, and we covered a lot of information in a short period of time. And we certainly felt very supported by the staff champions. I get a great intrinsic satisfaction out of working on this committee. I don't know if I were to wind up in A&E tonight, would I notice a difference? I don't know, on any one day or shift, maybe not. But I would like to think that it has helped, that one patient somewhere, one doctor somewhere has taken this on board, and, that there is, it's building on what's there, and it's becoming embedded in the culture here. So I suppose the challenges were not to take on too much in the implementation committee and not to boil the ocean, as they'd say in industry. So to overcommit, and then we lose momentum. And, you know, the hospital might think, oh, here's another thing, you know, that's going to come and go, and it's not going to get embedded. So I suppose we just had to, just take on one thing at a time. So that's why we spent a lot of time doing the terms of reference on the implementation committee. I suppose I had, you know, expressed an interest in being involved in staff education, I suppose, was what I wanted to be involved in. And so to that end, I've been asked to do and participated in 3 induction training sessions. So the first of those was with the non-consultant hospital doctors last July. So the very first hour, I think, that they set foot in Mayo University Hospital was listening to myself welcoming them to the hospital. So that just sets the tone for their internship at the hospital. And then again in August, September time and January, there were myself and some of the other patient experience advisors that welcomed the 4th and 5th year medical students on their first day at Mayo University Hospital. They had an hour-long session kind of with us where we presented some of our experiences on the hospital, what we were trying to do. So again, it sets the tone from day one with them, and we've received hugely positive feedback on that. Also, I had a workshop, kind of a breakout session at the Quality and Patient Safety Symposium back last October here in Mayo University Hospital, GMIT, and opened kind of the workshop, or opened the symposium on that day. So very honoured and privileged to be invited to do that. And there were many of the other patient experience advisors throughout the day that did sort of MC and various different things as well. And we also, as a group, we have presented, so that's the staff champions and the patient experience advisors. We've presented at a number of kind of seminars in NUIG, UCD, and you know, there's been a few of them in the past kind of year and a half. And as Fiona had mentioned, we have done our patient stories on video. Now, I know, again, from the pharmaceutical industry, one of the things that we do every year is annual GMP training, so good manufacturing practice training. And as part of that, we would typically watch a video from one of our patients, okay, because again, it's patients we're talking about, I suppose, in the pharmaceutical industry. And sometimes that's a good news story, and sometimes it's not a good news story. It's maybe where a batch had become contaminated or something like that, and the impact that had on that person's life. And it's annual training that we're required to do by law, I think, by HPRA and FDA. So we have to do that, or we can't. Like, so every person in the plant has to do it. And I suppose my suggestion, I think, at the time is that, you know, when we have edited these videos, that, you know, perhaps something like that kind of annual refresher training, just to keep embedding it in the culture with the existing staff, and that's potentially the use of those stories. So I suppose the Patient and Family Engagement Implementation Committee, as Fiona said, we started off in April 2017. We had 12 members at the time, comprising staff champions, the 4 of us from outside the hospital who had recently experienced care in the hospital, and there were some from the National Safety Committee as well. We met monthly, and in fairness, we always had a quorum, and we met monthly. And within that, after setting up the terms of reference, we divided into 3 subcommittees. So one of the committees focused primarily on the recruitment, and another focused primarily on induction and support of ourselves and the new advisors coming on board and the staff. And I suppose education, I suppose that, as I said, was the subcommittee that I felt, you know, most keenly that I wanted to be involved in. So what were our deliverables out of that implementation committee was to set out and recruit around 20 patient experience advisors to be the voice of patient on various hospital committees, as Fiona has described there, and to set up then, coming out of that, once we had established ourselves, to set up a Patient and Family Experience Advisory Council. So we had our first meeting there last month, and it was a really positive, enthusiastic meeting. And we elected a chairperson in our very first meeting. We started looking at the terms of reference for that now. And the chairperson will attend the hospital management team monthly board meeting, and did in fact attend the one in May. And if the chairperson is unable to, any one of the deputies will attend the hospital management board meeting. So I suppose our next steps for the Patient Experience Advisory Council is to develop a frame of reference for that council. And we would be looking at picking maybe 1 to 5, but our top 3 items, again, we don't want to overcommit ourselves, but to pick a number of items of priority to work on from the National Patient Experience Survey, and to work on that. Develop a cross-linkage as well, because not all of the patient experience advisors that are on the hospital committees are on the council, and vice versa. So to cross-link between the council and the other patient experience advisors, and also then to ensure two-way communication between the patient experience advisors and the hospital management team here in Mayo University Hospital. And then it's education of existing Mayo University Hospital staff, and increasing the ongoing interaction between the patient experience advisors and the staff to embed this in the culture and affect real change. So they're kind of, the immediate goals we have for the Patient Advisory Council. So I suppose really for us it's all about, as Fiona had said, nothing about me without me. But a patient, speaking from the point of view of a patient, and I know there's a meme on Facebook that you may have seen, and it might be slightly irritating, so I prefer this one that Fiona, I'm plagiarising from Fiona, but there's a meme where the doctor says, well, don't confuse 20 minutes of a Google search with my 7 years of a medical degree. And the patient comes back with, well, don't confuse your 1-hour lecture on Addison's disease with 20 years of living with the condition. So I suppose what I'm trying to say here is that the patient is an expert on themselves and their life. And what you'll often hear a patient or a family member say is, he's just not right. He's just, he's just off today, or he's not himself. And, if you explore that as a medical health professional, you then have the medical expertise to come out with the diagnosis and the prognosis there. So it should be a two-way street, and it should be respectful and collaborative. So that, you're the experts on the healthcare, and that's why we've presented to A&E, because we can't help ourselves anymore, but we're the experts on why today is different than yesterday for us. So I suppose my key takeaway message as a patient experience advisor is respect. So to regard your patients with respect, engage and listen with your patients. If you just take the few extra moments and listen to what they're saying, you could learn so much more. You could save a lot of time on unnecessary tests, potentially, know when to discharge or admit somebody, etc. Staff have the medical knowledge, but patients and the families know themselves. And explain things as simply as possible. I mean, I do have a degree in biochemistry, but when I'm at my most vulnerable and I'm in the bed there, in a gown, with my nether regions hanging out, I'm not going to be taken on board, medical lingo and things like that. So explain it as simply as possible, and then clarify that I've understood you and that you've understood me. So maybe just paraphrase it back to us and make sure that we both understand each other. And to teach yourself or learn from your mistakes and apologise if appropriate. Like sometimes it's, and I know we're getting into we're in a very litigious society, unfortunately, and you may not be able to apologise for, a massive mistake or something like that, because it's maybe perceived as an admission of guilt. But sometimes a very simple apology on the day, in real time, when something happens, when something goes wrong, that can just, head a load of stuff off at the pass without it getting into a serious incident. So I suppose that's my key takeaway message, and thanks very much for the opportunity presenting here today. I'll hand you back to Catherine.
So as Rachel said there, have things changed? If she walked into the ED department today, would it be different than it was? And I couldn't say absolutely that if she walked into the ED department today, her experience would have been different. But what we can say is the patient's perception from the patient experience survey has shown that, it has made a difference. So like in a 12-month period, you'll see there on the results from the patient experience survey, just on the heading areas, things have improved. So in a 12 months that coincided with having, genuine, meaningful patient engagement and patient-centered care as a result of that engagement, and I suppose to complement the engagement, because it's not just about that, it's about refocusing everybody's approach to how they interact on a day-to-day, minute-by-minute basis with their patients. So we can see that the overall rating, we went up by, 0.1, but that's significant. And I suppose in the areas where it really made a difference regarding how we interacted with the patients was an examination and discharge or transfer into community care, whereas we were significantly below, in fairness, the national average in 2017, and with an absolutely targeted approach to how we were doing service delivery and how we were interacting with patients. Not alone have we, met the national average, but we exceeded it on those areas. And it has to be part of the approach that we've taken for quality improvement and trying to make sure that we have sustainable, efforts towards having patient and family engagement in what we do. So I suppose that's the measurement we have at this moment. There are other ways that we can look at this in the future, but we're lucky that there is another patient experience survey looking at all of the areas, and that's what's going to guide us moving forward. Rachel also mentioned that, we had George, who is our chairperson, present to HMT, and it was such a momentous occasion to think that we were sitting at the hospital management team meeting and that we had a patient experience advisor present in where everybody was listening, and think, over 2 years we've gone from aspiration to action on it. So it's been a good journey, and I suppose we're very grateful that you've asked us and allowed us to share our story with everybody else.
Thank you so much, Catherine, and thank you to Fiona and also to Rachel. Great to have your inputs today, and I think Seamus is in the background there as well, so thank you to all of you. We do have a number of comments and questions in the chat box. If anyone would like to ask anything, please do type it in. But I just think it's nice to round off on this comment that came in from Sarah Ronan. She's saying that she's a staff member in Mayo University Hospital and she sits on many meetings where patient experience advisors are participating in shaping the way we do business. It took some getting used to at the start, but has been an entirely positive experience, definitely worth embracing this approach to quality improvement. Well done to all involved. So I think that's a lovely comment for somebody who's sitting on the other side of it. I suppose just to say, obviously this has been a long journey and it started over a number of years ago, and you've brought us through a lot of work and a lot of commitment from a large number of people within the organisation, your QI journey, your engagement with Canada, the planning, the recruitment, the implementing and the sustaining. So, just for our listeners, I think there was a lot of really nice practical information there in terms of how you actually move this along through the number of steps. We might just address some of the questions here in the chat box. Valerie Toomey had a question there around how do you measure the impact of the committee and the advisors, and I suppose there is a piece that even in my head that's coming in there in terms of even the patient experience advisors' experience of sitting on a committee. Is there some way of measuring that or getting feedback from the advisors themselves in terms of how they feel their voice is being heard at the committees?
Yeah, I think that is something that we have actually discussed at our implementation committee, Roisin, and we haven't actually designed anything as such yet, but we've had the feedback we've had has just been sort of very verbal, informal feedback, both from sort of the committee members where you have your advisor sitting and from the advisor who's there. But we do actually need to put a more formalised structure in place, and that will be part of the work that will roll out hopefully from the Patient Advisory Council.
And can I just ask about the Patient Advisory Council? I think, Rachel, you'd alluded to the fact that some of the patient experience advisors aren't on the council. But is there a forum, just to be clear for the listeners, for the 20 or how many patient and safety advisors you have that you can just come together yourselves, or is it through the council?
Yeah, I believe, again, it's one of the things that we have to set up and we have to formalise, but absolutely that would be the plan, and very soon as well, within the next couple of months.
Yeah. Fantastic.
What we actually did in March of this year, which was so in March 2019, we did our induction in March 2018. People were working then over the year. So in March 2019, we brought all of our advisors together. So we had an evening where they came, they met each other. That's where we talked about setting up the patient council. That's where we looked at, well, who would be interested in being on it. Catherine from HMT had come to meet with the advisors at that evening as well. And so bringing those people together is very important and is something that is going to happen on an ongoing basis. But that's, as an implementation committee, that's what we've done. We've done it on a yearly basis at the minute.
And just one other point, at the first meeting that we had, it was kind of muted that what we would do is have a process where the patient experience advisors would meet in advance of the council meeting. So that the members that are on the council will be able to feedback if there's difficulties or any particular areas that they'd want to drive forward, so that it's done fairly timely and connecting in with the actual council meetings.
Okay, great. And Valerie has another question about the patient advisors. And do they have a period of involvement, like a tenure? Do they rotate on and off the group? Or if you're assigned to a particular committee, you're assigned to it and that's your committee, you have the onus to turn up at that committee?
No, we had set, initially at the outset, we had set a 2-year period, so people would be assigned to a committee for a 2-year period.
Okay. And also, in terms of how you decide who's on what committee, is there, people who have particular, do you try and match patient experience advisors who have particular experience around certain issues onto that committee, or is it just random allocation?
Seamus here. No, we try and match. Right from the get-go in the application form, we asked people what was their areas of interest. So we captured that. And then as the committees came forth looking for patient experience advisors, the leads would then contact our patient experience advisors that we thought might be interested and explore that. Also, I suppose one of the challenges is, and it's a good challenge, that the hospital committees then had to look at meeting times that would suit patient experience advisors, people who are working, people with family commitments. So again, some of our key committees, because we were supporting the chairpersons, began to change the time to try and incorporate the patient experience advisors, and overall that has worked well.
Great. Another question here from Joanne Finn. She's asking, did you have patient services or carers on the implementation group?
Yes. We had. It started off with actually getting those to be part of it from this very, very set out of it. And we selected through different ways. Rachel explained there how we ended up actually reaching out to her. So we tried to make sure that we got people from different areas in the service as well. And I suppose a lot of the time where patients come to us, a lot of the time it is actually because they see an opportunity for improvement in service delivery. From their experience. So we did select people that had actually, identified issues that they would like to be involved in. And some had identified issues that we weren't aware of until they brought it to our attention. So we thought there was an immediate opportunity there to work together. But it was important, and that was one of the advice points from Canada is, and again, our own motto was not about me without me. So we had to keep pulling ourselves back and making sure we weren't going to make decisions as staff members without having the advisors being part of it.
Great. As Joanne says, it's a really great example of co-design, which is fantastic. I think there's a lot of interest around that recruitment piece, isn't there, from even our listeners online. It's very new, it's very novel, having this way of recruiting people in. And Joanne has asked, would you be willing to share your application form? Is that something that we could put in the slide? Embedded into the slide set maybe when it goes up online, just for people to have a look?
Yeah, we're happy to share any of the elements and steps that were taken. I think
that's fantastic.
So we looked, we would have looked internationally at what they were using as well, and sort of used that to help us shape our form.
Okay, fantastic.
And just to say, Canada and America would have said to us in relation to identifying possible people who might be interested, was to go through the hospital service, talk to our colleagues to identify potential people who might be interested, or that those staff members could have those conversations with patient and family, I suppose, because here it is about patient and family engagement. And we weren't looking for yes people, to pat us on the back or who could, work with us compliantly. We wanted people who could name the issues for themselves and their families, but who could work constructively with us, who had worked through their issues to a degree that we could work in a collaborative fashion. Because again, Canada, and Eleanor Rebar was one of the consultants, and she was very much saying, if a person is in the middle of their issue and trying to resolve that, then they are not, as Fiona said earlier, in that space where they really can work and see the bigger picture. Because that's the other aspect, that the patient or family member needs to see the bigger picture, not alone in relation to their own story, but the stories and experience of other patients and families. So again, we were very mindful of that Canadian influence when we started the recruitment.
And can I just ask Seamus on that, so say for example, did you have any applicants that, perhaps applied in and didn't meet that criteria, weren't deemed that they were ready to perhaps, be in a committee and ready to act in that? And how did you deal with those
I think the information night, Roisin, was good in that instance, and that like some people came, we had about 40 people came that night, and some came to just cite maybe an experiences they had, or that they had witnessed somebody in the hospital experiencing a bad experience. But what we found was that in the process, in relation to we sent more information application, they tended not to come forth. And I think there may have been one person when it came to interview that we had to say that this might not be the time for them, but maybe into the future.
And I think it's great what you were saying there about, your advertising in local papers and that. It's a fantastic way of getting it out and getting a wide reach, isn't it, to try and to get people involved. Are any of the patient engagement advisors also staff of the hospital? Another question from Joanne.
No,
but interestingly, not that I know of, but interestingly, when we had the foyer open day back, I think in August 2017, there were a number of staff, and I mean every staff member would have had a loved one or themselves in hospital at some point. And there was feedback. There was some very interesting feedback. One of the nurses I remember quite vividly, I think one of her parents had died, I think, in a month or two before that. And, it was just the simple things. God, there aren't enough chairs in the kind of, or outside the the mortuary or the kind of end of life ward, not ICU, but, and I think her family had contributed to donating some chairs. Just simple things like that she didn't see when she was just a staff member walking past that corridor every day. But then when she was at the other edge of the other side of the service. So we got some very beneficial feedback from staff as well, who themselves had been either patient or family members, experiencing service.
And I think on that approach, we had actually put the word out, because we had, obviously, post-recession, there was a significant portion of the hospital staff who took early retirement. And we actually thought that they would come back as patient experience advisors from the other side. But actually, we had none of our ex-staff applied to be it, but the feelers were put out. But again, we felt it was really important as well on the get-go that the staff engagement and the patient engagement committee, are very much, one process going forward. And that's why it's, getting a project to drive forward with patient engagement without it being part of an overall hospital approach to, achieving what is expected of us as a health service. It will just sit as a project, and it won't sit as part of the overall responsibility for running a hospital. So it really is important that the staff engagement and the patient engagement forum work in tandem, even from a training in relation to engagement, because if you engage well with your staff, you'll engage well with your patients. So, we hope that will develop in time.
Yeah. Just one final thought. If there's any other questions, you have a minute to just type them in there. But one other thought from me, I think, that came across quite strongly throughout the slide set was, I suppose, that idea of giving time to this. It's not something that you can do overnight. It's that, you know, building the trust, the psychological safety among the group, and, you know, getting that new way of working and established and giving time to that. Would you say that that's been a critical factor, success factor for the work thus far?
Oh, absolutely, Roisin. It has taken a lot of time, and it isn't fast. It's a slow process, and we're hoping sort of that we'll make it more sustainable through the way that we're actually doing it. But yeah, it's been a big time commitment. But I suppose everybody's been driven towards it, and so it would be perhaps ideal in a way if somebody had some time specifically maybe assigned to drive it forward. But that, you know what I mean, that's not the way it happened here. So myself, Seamus and Maeve, we're sort of totally committed, and sort of we spoke with Catherine, and then once you start to work with the patient experience advisors, once you have your implementation committee there, you're sort of driven on by the work itself. But no, it is, I'd have to say it is a big time commitment.
Yes, and just talking about time, Roisin, that also in relation to allowing the process and the human relationships to build between the patient and family experience advisors and staff. So we could have rushed it, but we went into slower gear in order to try and ensure that it would work, because we could have thrown patient experience advisors onto committees and actually we'd have thrown them into the deep end of the pool. Also staff, like say in relation to medication safety committee, that's a big step for an acute hospital medication safety committee to bring on board patient experience advisors. And of course, staff did have concerns in relation to confidentiality and very complex and sensitive issues being discussed. So it's building that trust and the confidentiality piece. Confidentiality is part of the agreement with the patient experience advisors. So again, there was a time factor there in building all of that safety and foundation, isn't that correct?
And I think, as Fiona said there, Canada were very much of the, I suppose they said from the outset that you need to have a designated person that has this role, and this would be their sole role. And I know for a fact, you know, when we heard that first, I was thinking, like, we're not going to get that person. It means applying for a new person and finding a new post and creating a need for it. And if that was what stopped, then we wouldn't even have got to actually putting an advert out or putting a, you know, so in fairness to the team that led it out in the hospital, they did it as part of their job, and, you know, they readjusted how they worked. And there was, like, the three senior people was, you know, Seamus, Fiona and Maeve Rhiannon, who's a consultant in obstetrics and gynae. And really, if people aren't willing to do that on the side of your desk, as they would have said from Canada, but unfortunately we got this. And whilst I know it's 2 years, but it's a huge shift from where we were to where we are. I actually think it's moved very quickly. Thinking of all of the people, like there's 1,300 staff that you have to influence to a different way of working, and you know, it's a lot to achieve in a 2-year period of time. And I think the feedback from Canada in our close-off meeting was that, you know, it was actually achieved much quicker in our hospital than it was in Canada at the time. Now, perhaps because they were leading out internationally and we had all of their learning. So, you know, 2 years is a very short time, I suppose, in health services.
Yeah. Actually, that's what we felt when we sat down to pull the slides together. We actually thought, do you know what, the time?
There were times, I suppose, within it. And I remember going to one of the meetings, I think we were about a year in, it was maybe April 2018. What did we do, like, in the year? But it was actually, we were sitting down, we were reviewing the year, and we went, oh my God, we did this, you know. So I think, just looking back on it again, formulating the slides for this presentation, I think it has moved very fast for what we're trying to do. And I suppose, you know, to build that trust and slowly, rather than to rush in, be a flash in the pan, and we wouldn't have succeeded, like, because, you know, somebody somewhere would have not been ready, you know, and, you know, whether that be the advisors or it be the staff, you know, I think if we'd rushed headlong into it, it wouldn't have been the success. Like, slow and steady wins the race with this particular thing.
Well, I think on that point, it might be a nice point to end on, to wrap it up. Thank you so much to all our QI Talk timers who've logged in and listened. We hope you got a lot from today's QI Talk time. Thank you again to everyone in Mayo who've helped facilitate this and sharing and imparting your wisdom and knowledge in the area. We certainly will have this up online by the end of the week, so you can have a look, and we will integrate the application form into the slide set as well. So thanks again for your time. And just if we move on to the next slide there, this is our 13th webinar of the first 6 months of the year. We've one more left before we take a break for the summer, but we would really value some feedback from our listeners. So there is a Survey Monkey. The link is in the chat box there if you would like to feedback. So just anything at all that you want to bring to our attention, or the topics that you would like covered. If there's maybe a local improvement initiative in your hospital that you think would be nice to share nationally for potential spread, please do fill it in our Survey Monkey. And just any ideas about how we could improve QI Talk Time, it would be great. So please please click on the link, and the more responses we get, the better. And just lastly, our last QI Talk Time of the season is on Tuesday, July 2nd, and we have the team from the Quality Improvement team, the Medication Safety team, are going to speak to us on the No Check Ask campaign. So please do join into that. I'm sure there'll be a lot of interest, maybe even in Mayo as well, so hopefully you'll be able to join in. So thanks again to everyone for logging in, and hopefully we'll see you again on July 2nd. Thank you.
Thanks, Roisin.
Thank you.
Thank you.
Thanks.